Okay, welcome to part 2 or continuation of our presentation on hypertension. We left off talking about secondary hypertension and we covered renal artery stenosis as the primary cause. But there are other causes of secondary hypertension. And so we're going to begin talking about some of those lesser causes. It doesn't occur as often, thank goodness, but there is coarctation of the aorta that can lead to secondary hypertension. Coarctation of the aorta is one of those congenital defects, congenital narrowing of the aorta, and it occurs when the aorta carries blood from the heart to the body is pinched or narrowed. This obstructs the blood flow from the heart to the lower part of the body. The blood pressure above the narrowed area is increased. There are usually no symptoms present at birth, but they can develop as early as the first week of life. So a baby may develop congestive heart failure or high blood pressure that necessitates early surgery. Otherwise, surgery usually can be delayed. A child with severe coarctation should have surgery early in childhood to prevent complications, such as development of high blood pressure in adulthood. Endocrine disorders also can be responsible for secondary hypertension. A big one that they like to test on in nursing is a disorder called pheochromocytoma. This is a rare tumor that usually starts in the cells of one of the adrenal glands. Although they are usually benign tumors, pheochromocytomas often cause the adrenal gland to make too many hormones. These are stress hormones that can lead to high blood pressure and cause symptoms such as headaches, sweating, a pounding heart, chest pain, a feeling of anxiety. Okay, some of these cells secrete hormones such as epinephrine and norepinephrine. These hormones will regulate the heart rate and blood pressure. When they secrete excessive amounts of these hormones, this results in periods of very high blood pressure. And only about 10% are malignant, but we have other diseases as well. Cushing's syndrome, hopefully you've learned about that in the past. And also with Cushing's, remember that it increases the blood volume, and therefore we have elevated blood pressure. And with primary aldosteronism or hyperaldosteronism, there's an increase in aldosterone, and that, remember, causes a retention of sodium and water, and that increases the circulating blood volume and therefore an increase in blood pressure. Okay, so now we're switching gears just a tad, and we're going to be talking about systolic hypertension when that upper number increases. We mostly see this in older adults. Let's say roughly half of the people with systolic hypertension are over the age of 65. So the incidence does increase with age. And that is a result of those arteriosclerotic changes that occur as a normal part of aging. We mentioned that as we get older, our arterial walls get stiffer. They're less compliant. Remember, they do have a muscle layer, but they're just not as compliant or pliant as before. And that stiffening increases the systemic vascular resistance. Okay? So hardening or stiffening of our vessels increases systemic vascular resistance, and that increases the blood pressure. Okay. With that increase in blood pressure, with mostly the diastolic number stays relatively the same, but because the systolic number goes higher, we see a widened pulse pressure. Remember, we did talk about what pulse pressure is in a previous lecture. So this is a case when they have systolic hypertension that we see a widening pulse pressure. So what is the treatment for systolic hypertension? Um, we want to lower and always lower blood pressure slowly. Not lowering it slowly, any sudden decreases can lead to stroke. Okay, so we definitely want to avoid that risk of having a stroke. So the rule is to start lowering their blood pressure slowly. We start at lower doses of antihypertensives and we increase it slowly. Okay, this is very important when we talk about treating hypertension, but it is actually a good rule for almost all medication administration. That's what they'll teach us in advanced practice nursing, that we start slow and, we start low and go slow. That is the general rule to avoid any type of complications with our patients. Okay, most patients who are hypertensive will require 2 or more antihypertensive medications to achieve their blood pressure goals. Addition of a second drug from a different class should be initiated when a single drug is in adequate doses fails to achieve their blood pressure goal. Okay, so we increase the initial drug and in an attempt to reach goal, but if we cannot increase it with elevations in dosage, we must introduce a second drug. So that's why you will see in the hospital almost all blood pressure patients are on more than a single medication for blood pressure. Orthostatic hypotension is one undesirable effect of these agents. The patient may feel dizzy, weak, faint when assuming an upright position after sitting or laying down. Syncope, fainting, occasionally occurs 30 to 90 minutes following the initial dose. Okay, so to reduce the effects of orthostatic hypotension, we want to instruct the patient to arise slowly from bed, sit on the side of the bed for a few minutes, stand slowly, etc. Especially older adults, because they are even more sensitive to these blood pressure changes. Typically, we will recommend that they take this medication at bedtime to minimize those orthostatic blood pressure drops. I'm not sure exactly why this was introduced here. I think mostly just to reinforce what we mean by blood pressure, but we've already gone over this diagnosis. Hypertension is a sustained mean arterial pressure, and to do that we have to have several blood pressure readings. We don't ever diagnose hypertension with a single blood pressure reading. Okay, we want to see several and on both arms, and we would want to have a systolic greater than 140 and a diastolic greater than 90. Remember that the definition of blood pressure is that force exerted by the blood against the inside walls of the blood vessels. This sustained mean arterial pressure causes damage, especially over the long term. Let's talk about now signs and symptoms of blood pressure. Okay, as we mentioned earlier, it's a silent killer or silent disease. They frequently don't have any symptoms at all. However, if they do have symptoms, they're minor and frequently they're ignored by patients, and they may not even know that they have hypertension. So if they do have symptoms, a common symptom would be a headache upon rising in the morning. And this is related to the increase in fluid volume that they have. Their headache, they describe it as being in the occipital region and as a feeling of stiffness or tightness. Okay, those are big indicators that they likely have hypertension and that they should get their blood pressure checked and monitored. It's called a silent killer because it's late in the disease that a patient may become symptomatic. Now we have to mention, well, we already mentioned the classifications, the different classifications, but here we want to stress the fact that in the elderly, as we see in this patient, drug metabolism and distribution of drugs are altered. Okay? Therefore, it's especially important to begin treatment with smaller doses. Okay? As we mentioned earlier, the older patient is more susceptible to changes in blood pressure. So also, in general, like we want to mention here, that elderly people, as a normal part of aging, their kidneys and their liver decline. And so they are not able to metabolize drugs as efficiently as they did when they were younger. Now, there is severe hypertension. Looks like we missed a page, and that's real important, so I hope I'll include it in the next segment. So there is something called severe hypertension, and these people have a headache when they have severe hypertension, and that headache is related to the changes in the cerebrospinal fluid. Other symptoms when they have severe hypertension is that they get tired easily. They may feel dizzy or lightheaded, have heart palpitations, even blurring of vision, and nosebleeds can result from severe hypertension, epistaxis. Okay, so hypertension is a common comorbid condition of other diseases, especially diabetes. And diabetes affects a majority, hypertension affects a majority of people with diabetes. Hypertension is also a major risk factor for cardiovascular disease and microvascular complications such as retinopathy and nephropathy. So there is a proportional increase in the risk of heart attacks, myocardial infarction, heart failure, stroke, and renal disease with higher blood pressure. As a result of microvascular damage, these organs are also damaged, okay, especially over time. So although, a blood pressure, elevated blood pressures won't generally cause symptoms or need immediate treatment in terms of saving lives, sustained hypertension over time really destroys the microvasculature and the perfusion of all of these vital organs. And we need to talk about coronary artery disease, abbreviated CAD. Hypertension means that the heart is working harder than normal and putting both the heart and the blood vessels under strain. There is a direct relationship between hypertension and cardiovascular disease. Hypertension is considered a risk factor for coronary artery disease. And coronary artery disease is a primary cause of heart failure in the United States. Coronary artery disease increases because of the increasing rate of atherosclerosis, which is the thickening and deposition of plaque within the walls of the coronary arteries, and this leads to the increasing pressures. This buildup of atherosclerosis, this plaque, is also associated with these coronary arteries getting thinned walls. And actually, the thinned walls can rupture, but it's also responsible for aortic aneurysms as well. So the aorta, even the aorta, can have these thinned areas of the vessel wall, leading to aneurysms and rupture as well. Okay. We know that hypertension is also a leading cause of stroke. As we also know that the blood vessels, as a result of hypertension, are damaged and they become stiff and rigid. They're very fragile, and as a result of hypertension. And so sometimes the that added pressure can lead to the vessels rupturing in the brain and lead to a hemorrhagic stroke. Nephrosclerosis is also associated with hypertension. The hypertension leads to the scarring of the nephrons and the kidney, and it eventually leads to chronic renal failure. There's destruction with the high blood pressure. It's microvascular destruction of all the little glomeruli in the nephrons and the tubules. As a result of this destruction, we see the elevation of waste products in the bloodstream, and that includes blood urea, nitrogen, creatinine, and potassium. So this is kind of a nice major concept to have. When there's kidney damage, we're going to see an elevation in our BUN, blood urea nitrogen, not bun. We're not bakers and we don't put them in the oven. So this is a blood urea nitrogen and creatinine and potassium in people who have a compromised kidney. Okay. This is what nephrosclerosis looks like. The pathology of this kidney, we see a bumpy outer surface, and all of that is damage resulting from hypertension. Okay. We also see damage to the retina of the eye. Of course, as a nurse on the floor or unit, you're not going to be using a ophthalmoscope, but if you go on to advanced practice, you will learn to use an ophthalmoscope and look into the fundus of the eye. That by doing that, you can visualize the blood vessels, and there are significant changes when people have hypertension. Okay, and you do need to know this, even though you may not be practicing that skill. They like to test you on it so that you understand that the damage that occurs with hypertension can affect vision and the retina of the eye. So let's see, they can become, patients with high blood pressure can have loss of vision, they can have blurring vision, and they can even have these little retinal hemorrhages visible in the fundus of the eye. And so here's a picture, a diagram that shows you the damage that can occur from hypertension to the retina. You should be able to identify these findings. For example, the flame hemorrhage, the little red spots, these manifestations, retinal hemorrhage. Also, we'll see these hard exudates and cotton wool spots. Okay, all of those are manifestations of severe retinal damage. That's why our patients who have hypertension need to have an annual eye checkup to make sure that they are not having this destruction. Okay, this is a beautiful picture of what we saw on the previous diagram. But in addition to the flame hemorrhage, hard exudates, and cotton wool spot, we see another finding called papilloedema. So papilloedema is a swelling and around the optic nerve. So this too can cause a blindness and loss of vision in people with hypertension. Okay, this is in the later stages. We see this picture is grade 4 hypertensive retinopathy, so that you understand what we are talking about when we say hypertensive retinopathy. Okay. When it comes to making the diagnosis of hypertension, we don't use a single reading. We take several readings over a period of time. We take readings in both arms, okay, each time. We do know that the importance of taking accurate blood pressure measurements. Make sure you know that. I think you've studied it earlier in the program. Blood pressure measurements of both arms are performed to detect any differences between the arms. Atherosclerotic narrowing of the subclavian artery can cause a falsely low reading on the side where the narrowing occurs. Therefore, the arm with the higher reading should be used for all subsequent blood pressure measurements. You also may, the patient may have to go for diagnostic tests to rule out secondary causes. Perhaps they're going to have an arteriogram to make sure the renal arteries, there isn't any stenosis of the renal arteries. Okay, so other diagnostic tests can be used to rule out any secondary causes. Okay, initially the immediate treatment is going to be lifestyle modifications. That's considered conservative therapy. So lifestyle modifications should be used in all patients with prehypertension and hypertension. The modifications include weight reduction, DASH eating plan, dietary sodium reduction, and moderation of alcohol consumption, regular aerobic physical activity, and the avoidance of tobacco use altogether. I just will mention one thing here. When it comes to low sodium diet, this patient should be told that to avoid salt substitutes, because we know that salt substitutes contain potassium, and this may cause hyperkalemia. Hyperkalemia has a risk of life-threatening consequences. So this is something we want to mention in our education to patients as well, to avoid salt substitutes. Okay, some patients need to be taught how to read food labels. They need to know what foods are low in sodium. They have to learn how to read labels to identify foods that are high in sodium. And they need to be warned about avoiding salt substitutes, and also they should not add salt to their foods. Okay, weight reduction is very important in managing blood pressure and getting that blood pressure down. When we talk about exercise, we mean moderate exercise. Never choose strenuous exercise. What's important is that the exercise is isotonic, moderate, and regular. Okay? Isotonic means walking, swimming, biking. Those are all excellent forms of isotonic exercise that will help to lower blood pressure. Isometric exercises, and the one we talk about here is like lifting weights, is not going to be effective in lowering blood pressure. Mhm.